For open operative intervention, the patient is positioned supine with arms out to the sides. A generous upper midline laparotomy is made and the fascia is opened in the midline. Any intra-abdominal contamination or hemorrhage is evacuated and a self-retaining retractor is placed and the ulcer is located and assessed. A tongue of omentum is mobilized using an energy device. Once an adequate tongue of omentum has been mobilized, attention is then turned to the ulcer. Using 2-0 silk stitches, generous seromuscular bites are taken on either side of the ulcer. Of note, prior to repair of the ulcer, the surgeon should decide whether biopsy of the ulcer is indicated. In this case of a perforated gastric ulcer, after biopsy of the ulcer base, we proceed with open gram patch repair of the perforation. The tongue of omentum is then passed under the sutures or simply laid on top of the sutures while the sutures are then tied over top of the omentum. After repair, distal feeding access and gastric decompression is left to individual surgeon preference. We prefer to leave a nasojejunal tube via one nair for feeding access and a nasogastric tube for gastric decompression via the other nair. Additionally, we leave closed suction drains in place.